Hello, everybody, and welcome to my show. I am thrilled to be here. My name is Lucy McBride, primary care doctor in Washington, D.C. And today I am joined by Adam Cifu, who is a distinguished internal medicine doctor in Chicago, educator extraordinaire, and medical writer. I was looking at your bio, Adam, and I didn't realize. I knew how extraordinary your writing was, and I've watched your I've kind of read everything you've written, and so it wasn't surprising to me that to see that like 17 times in a row the the medical students have voted you as like favorite professor.
Yeah.
That's awesome.
In the past, no longer.
Well, you're humble, but I think
Yeah.
and like one of my favorite sayings is "make humility great again." So
Right.
I think that's a good place to start, right? When we're thinking about medical news and information, and we're trying to guide individual patients or large swaths of the population, we need to be humble about what we don't know.
Sure. Sure.
And that is maybe a good place to start. Today, we're going to talk about the COVID guidance that's coming out of the FDA, out of RFK's mouth, and out of the CDC.
Yeah.
We're going to talk about what happens when science and politics mix. And we're going to talk about where that leaves the average American who's reading headlines, reading the news, and
Sure.
worrying about COVID and what to do. And I think thinking about COVID is actually a great way to think about what we do in medicine every day in
Yeah.
general. Balancing risk, understanding the person in front of us, understanding people's unique tolerances for risk, and helping them make complex decisions because there's sort of no simple solutions in life. There are only trade-offs, in my
Right.
opinion.
Right. And I agree with that. And I think one of the reasons that COVID was so difficult for so many people is it really highlighted a lot of the uncertainties, a lot of the nuances that we deal with in, primary care, in medicine so much, but it sort of made everybody aware of it in a life and death situation. And it was more than many of us could handle, certainly more than our system could handle.
Yeah, it was the ultimate stress test of public health institutions. It was
Yeah,
the stress test for doctors. And I mean, I think that we walk around in our regular lives not thinking about risk very much.
yeah.
I think we take for granted how lucky we are to be alive,
Mm.
or at least I do.
Right,
And I think that everything we do, every health decision we make, whether it's about a vaccine or getting in a car or being in a relationship with another human
right,
being,
right.
carries risk. And there are risks of doing things, and then there are risks of not doing things. So
Yeah,
at the end of the day, one of my favorite expressions of late with patients is there are no solutions, there are only trade-offs. Like there's no menu option here for COVID not to exist. We
yeah,
have to grapple with the risk of the vaccine versus the risk of COVID itself. And in general, the risk of the vaccine is minuscule and the benefits are there, but they depend on who you are as to how high
right,
the benefits are.
right. And I think what's interesting, just to pick on a couple of things that you mentioned. One, I think we know from a million studies that we are bad at assessing risk and balancing risk in our lives. That's kind of a given. Um, Two, I think with COVID, that certainly increased our risk of getting ill and potentially dying at every day. Right, the risk was still very small, but much greater than none of us wake up in the morning and say, oh, there's a 0.25% chance that I'm going to die today, right? Um, and so I think that's one of the things that made it so hard for so many people is the only way we can live is to imagine that, we're fine and we're going to be fine every day. Um, and then I'm sure we'll get into talking about it. Right. The risk of COVID is very small, fortunately much, 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 much smaller than it was 5 years ago, right? Um, and the benefit of a vaccine is there, but one of the difficulties with making recommendations is that um, while we could all turn to the same New England Journal article from winter of 2020 and say, look, these are the results in unvaccinated people who hadn't had COVID, the disease is different, the virus is different, the people are different now, that a lot of doctors, we just struggle in what to tell people. And people clearly struggling what kind of decision to make, and they're voting with their feet, right? How few people are getting vaccinated these days.
I couldn't agree with you more. There's so much to unpack here. I'd love to open with the FDA's announcement or, article in New England Journal of Medicine last week, written by two people you and I both know, Marty Makary and Vinay Prasad, who are controversial figures, particularly right now, and who are sensible and smart, educated people. Some people who are watching right now may be surprised to hear me say that. Just because they're in the Trump White House doesn't mean that they're, saying the wrong thing.
Right.
I don't agree with our boss, RFK, on a lot of issues. I have serious concerns about his qualifications and messaging and ideas. But when Marty and Vinay came out with their article in the New England Journal of Medicine, I thought, okay, first of all, this could be a lot worse based on
Right.
what I was
Right.
expecting.
Right.
And secondly, this makes sense. It is true that people over the age of 65 in general, cohorts of people over the age of 65, not every 65-year-old, are at the highest risk for severe outcomes from COVID, hospitalization, death, oxygen requiring illness. Um, and it is true that people under 64 in general are at lower risk, but at higher risk if they have an underlying comorbidity. So that actually made sense. What concerned me, as I believe it concerned you, is the path by which they made that announcement and kind of bypass some of the typical channels for making those kinds of recommendations, which of course is alarming. But when it comes to the basic science and the basic messaging, I thought it was pretty good. It left a lot of questions open, but it was pretty good.
Right. So I actually applauded that statement pretty much across the board. And what I appreciated about it is that it was so transparent, something that, we're not used to seeing, right? It was that, look, this is where, we are still sure there's benefit to this vaccine, and we're going to let people make the decisions as they would with their doctors normally, right? Um, this is another area that we really honestly don't know at this point. Um, and we're going to tell you exactly what studies we need to be convinced, what the efficacy of the vaccine is necessary for us to approve that. Telling the companies who've been making, heaps and heaps and heaps of money, like, hey, just show us that this works, and we will be behind you. And I understand that there's a lot of nuance here, a lot of confusion, a lot of things that we can disagree with, and I'm sort of fine with that. Um, I have to say that the general reception to their article depressed me, because so much of my media reacted to it as like, oh, this is terrible,
Yeah,
without kind of thinking about it and saying, this kind of makes
yeah.
sense.
Yeah, and at the risk of sounding like a political operative, which I am not, like this is, I will point out that the New York Times headline said FDA poised to restrict access to COVID vaccines. Now that was not actually the take home from that piece. That was an example to me of a journal that I subscribe to. I pay the New York Times lots and lots of money.
Yeah.
I like their journalism. I like their writing. I disagree with a lot of the things they some of their reporting and their headlines about science because they're outrage inducing, fear inducing, but I do respect a lot of what they put out. But that was an example of a hyperbolic headline designed, in my opinion, I'm guessing, to gin up fear and outrage. When the
It, it
substance
was
of
it
the
it was
yeah,
completely true, right? Um, but the connotations of that were so negative, compared to what was actually in the New England Journal article. And to be honest, what was in, most of the rest of that New York Times article, which did a reasonable job
yeah,
at restating what Vinay and Marty said.
yeah, it was the body of the New York Times article was as you said, it was reasonable. It's just the
Yeah.
headline was on brand with
Right.
what they're trying the audience they're talking to. And so like it's fascinating as you and I were both kind of watching the sausage being made during the pandemic, it opens your eyes to how detrimental it is to the general public when politics and science merge, and then when the media is deciding on its sort of tone of messaging, sort of rendering opinions about things
Sure.
that are supposed to be fact-based. Okay, so a lot of people are writing back to me on my article that I wrote today
Yeah.
about the COVID vaccine landscape, which is not an exhaustive review of the COVID vaccine
Yeah.
landscape, but I'm basically saying, look, the FDA came out with some reasonable recommendations, arguing that, what we already know, which is that 65 and up is higher risk, 64 and under with underlying conditions should get the vaccine, and then they left a lot of holes. RFK comes out saying, we're going to take the COVID vaccine off the pediatric vaccine schedule.
Right. Right.
Everyone freaked out,
Right.
understandably. And he also suggested that pregnant women shouldn't get it, which is
Right.
ridiculous because we
Makes no
already know
sense.
that pregnant women seem to be at higher risk
Right.
for severe complications from
Right.
COVID. And then the CDC was either negotiated with or they overrode RFK and came out with a more balanced policy. So a lot of people are writing me today asking a couple important questions. One, so what's the big deal? Like, why not just get a COVID shot? Why not get a fourth booster, a fifth booster, a sixth booster? Why all this hemming and hawing? And I really can't wait to ask you this question, Adam Cifu. Why not? I have an answer,
Uh,
but I want to hear yours.
right. Um, I so the COVID vaccine is safe. Let me sort of say that to begin with, okay? Um, the only group that I sort of carry some, a little bit of anxiety in, right, are young men. That they're the people who we see the myocarditis signal in, okay? And otherwise, the COVID vaccine is safe. But right, lots and lots of the medications that we give are safe, right? Statins, perfectly safe medication. Should you go on a statin when you're 25 with normal cholesterol? Absolutely not, right? We don't take medications that we don't need. And it's the same with vaccines because everything carries a small risk. And if there is essentially no benefit to a medication, to a vaccine, whatever, you shouldn't get it because it costs money, it causes harm, there are opportunity costs. There's a good chance you're going to feel like crap the next day with a vaccine. And so, to some extent, it's not a big deal. To another extent, we should know what we're putting into our bodies. And people look at this all across the spectrum. I mean, I certainly have patients, as I'm sure you do, who really need absolutely zero encouragement to take another vaccine. And then there are people on the other side who are very skeptical and absolutely need to be convinced. And we to have numbers to counsel all those people, which to a great extent for 4 years, we haven't had that.
Right. The quote I want to put out there that you wrote last week is medicine should offer care that people need, not what people want. So
I was very proud of that sentence.
I love that quote. I love that quote. Let's just I'm going to state it again. Medicine should offer care that people need, not care that people want. Now, reasonable people might say to that, well, that sounds, Dr. Sifu, paternalistic. That sounds like you're gatekeeping. That sounds like you are someone who doesn't want to give an under 64-year-old with no underlying health conditions a COVID shot. And I believe in individual choice. I believe in individual freedom. This is the United States of America, for crying out loud. If I want a COVID shot, I should get a COVID shot. I hear what you're saying, and I agree with you that medicine, our job as doctors, is to understand people's underlying health conditions, their nuanced, you know, medical conditions, um, and to help people make complex decisions based on their risk tolerance and the risk of the intervention and the risk of not getting the intervention. The problem is 100 million Americans don't have access to a doctor to make those shared decision making. So
Yeah.
it makes sense to me that people are looking for sort of simple algorithmic guidance when it comes to should I get a shot or should I not? Like, just tell me.
Yeah. Yeah.
But I think that your point is very well taken, that our job isn't to just give people what they want and say, here's an open, ended sort of all you can eat buffet bar of medicines and you pick. I mean, that's what we're kind of pushing against, right?
Right. I wrote an article a couple of weeks ago about parentalism,
I read it.
parentalism in medicine, trying to get away from the paternalism side. And I think, I think that my statement about we're here to give people what they need, not what they want, makes more sense when you think about what we do in care. Because if I have a 45-year-old completely healthy woman who says to me, I absolutely want the COVID vaccine. Will you give it to me? I'm honestly going to be like, yeah, sure, whatever, get the COVID vaccine. I will counsel her. I don't think this is going to benefit you at all, but I think the harms are nearly non existent. So take your vaccine. On the other hand, I mean, there are multiple times every week that I absolutely basically prevent people from getting care, right? Last week, I had an 85-year-old woman who was desperate to get a colonoscopy, which she absolutely did not need. You know, she'd been screened too late in her life already 5 years ago. It was normal. Her life expectancy is only 3 to 5 years at this point. And I would not let her get that care because I knew that the risks and the harms of that care were greater than any sort of benefit she could get. And that's how we have to look at all these things. And that's, the role of a physician. Um, you point out a um, a great fact. That in our conversation, we are depending on a doctor who's going to be very thoughtful about risks and benefits, who can sit down, who has can have a conversation with a patient, with that. And there are lots of people who don't have doctors. And then there are a lot of people who feel like they've kind of lost trust in us over the last 5 years. And so even if they were able to sit down with someone and have that conversation, um, they wouldn't really trust that we were taking their best interests at heart. And that's just part of the difficulty of both practicing medicine right now and I think receiving care right now.
Yeah, I think you're right. I love the example of the colonoscopy in an 80-year-old person. I think, I am more kind of like I just believe in the shared patient doctor
Yeah,
decision, right? So if a patient of mine who's 80 and wants to have a colonoscopy, I will explain that perhaps as you did with your patient, like there are risks of not getting a colonoscopy, but there are risks of the colonoscopy itself. And let's think about what the benefits of the colonoscopy are and the harms and then make an informed decision. I'm not going to lie down on a train track and not let you get a colonoscopy. Same thing with the COVID shot. If I have a 45-year-old patient or someone just wrote in their 60s, they have no underlying health conditions and they want to get a COVID shot, I'm not going to prevent someone from getting a COVID shot, but I will try to educate them to say that here are the benefits of the COVID shot. The COVID shot are the superpower of the COVID vaccine we're talking about now is its ability to protect the highest risk patients from severe consequences from COVID. Ever since the Delta variant came around in 2021, the ship kind of sailed on the vaccine blocking transmission. So
yeah,
it is true that getting a vaccine, getting the COVID vaccine, is going to reduce your it's probably going to reduce your total viral load, and it could reduce the risk of transmitting the virus to other people. So there are two reasons to get the shot, right? There's the preventing severe disease, preventing severe outcomes, which really it's only going to do for the people who are at higher risk for the severe outcomes in the first place. The other reason to get the vaccine is to reduce your viral load, perhaps to reduce your symptoms, and perhaps to reduce the likelihood of transmission to other people. But I would say, and I wonder what you would say, Dr. Cifu, that that's a very reasonable reason to get the vaccine. It's just that the vaccine's ability to do that is probably less than an intervention that would be an intervention like staying home when you're sick. Like when you're teeming with virus and you're feverish and you're chilled and you're coughing and your nose is running, not being around an immunocompromised person is going to serve that person better than you having had the vaccine.
right. Well,
It's not to say you shouldn't get the vaccine, but I just think it's important people understand what they're getting with the product they're asking for.
right. I think your hemming and hawing in that statement is so instructive, right? Because you are someone who does this, as their living, right? And you have paid more attention to this than most doctors. I've read your writing. I know that you've looked at the literature. I know that you work very hard to to give very clear advice to your readers, and I'm sure to your patients as well. And, as you spoke that, you had to like kind of twist your words to
Pretzel
say, oh,
myself.
right. And the reason that is because we don't have those numbers anymore, right? And so, yes, I tell my older patients they should get the vaccine. And I think it's helping them. And I'm going to continue to counsel them that they get it once a year. I don't know if twice a year helps them at all, right? I can't even tell them what the benefit's going to be for someone who's hesitant. Um, and then for all the younger people, I have no idea. And that's left me in such an uncomfortable position um, because I know those numbers about most of the things I talk to patients on. So when I'm talking about lowering a hemoglobin A1C in a patient of mine with diabetes from 8 to 7, I know the benefit of that. From 7 to 6.5, I know the benefit of that. I know how important it is or not important to go from a blood pressure of 150 to 140 or 140 to 130. Like those are numbers I can spew, you know. But on the other hand, the most important thing to a lot of my patients over the last few years has not been that, right? It's been, should I get the vaccine or, should I take Paxlovid for an infection when I'm 40 and I've always been vaccinated? I'm like, I don't know. I can't help
Right.
you here.
We're in a data-free zone. We're in a data-free zone. So we're left to use our judgment, our intuition, and the data that we have, and extrapolation. Um, I think people want to know the answer to this question. They've written to me about it today. What about the risk of long COVID? So people who are under the age of 65 who are so people who are not necessarily gonna get the vaccine because they're not high risk are worried nonetheless about the risk of long COVID. Like, does the vaccine not protect you against long COVID? Does it not protect other people? And as I said a minute ago, it could protect other people, but better than getting a vaccine to protect other people is just stay the heck home from work or school when you're sick. And get the vaccine if you want to, but I just don't want to I don't like over promising things. I don't like over promising on things that aren't going to deliver. So what about long COVID? I mean, this is a very controversial topic. I've written about it, but I write about it with a very high levels of trepidation for reasons you can understand. And so what would you say to someone out there saying, what about long COVID? Should I get another shot? I'm healthy, I'm young, or maybe I have chronic fatigue. What do you think?
Right. Um, so I also hesitant to get into this. So whenever anybody gets very sick, um, they have a potential to have lasting symptoms, right? We have seen this throughout our entire career, and it has nothing to do with COVID in particular. If you get a terrible, pneumococcal pneumonia and you're in the hospital with it, are you going to bounce back and feel perfectly a week later? Probably not. You're going to be fatigued. You're going to feel a little bit out of it, which we now call brain fog. Um, what was striking about this sort of post-illness disability, we'll call it, during COVID, is that all of a sudden we had millions and millions of people getting very sick with a new virus, and that's why we've seen them. Do I think there's something, special about COVID compared to other infections? I do. We've learned a lot about the effect on clotting pathways and so on and so forth. And my hope was that the effort at studying long COVID was going to really open doors into the other sort of post-illness syndromes that people have. I'm a little bit, disappointed so far that it doesn't seem like we've learned a whole lot there. Um, at this point, I have to say, with all of us, with great levels of immunity to COVID, either through vaccination or through previous infections, um, I'm not seeing a lot of people with long COVID, with new long COVID. I certainly can't say it doesn't exist, and I'm sure some people get a bad infection and feel crappy for a little while. But I don't think we're at a point where we're seeing people who are, acquire a long-term disability from COVID. I think where the vaccine helps there is it helps people get less sick from it, and so that probably helps. But I don't think that's a reason to, get the vaccine. And certainly if someone tells me, boy, I felt terrible with the vaccine in the past, it laid me down for a week. Oh, it sounds like a COVID infection. You should probably not go through getting the vaccine for you. I'm not sure that totally answers your question. There was a
No,
lot
it
of
does. It
hedging
does. I
there,
mean,
but
I think what you're saying, if I'm hearing you correctly, is that since the beginning of time, we've seen long-term sequelae from viral illnesses.
Yeah.
The mononucleosis virus, Epstein-Barr virus, the influenza virus, the flu virus. The immune response to the virus um, can render the recipient of the virus very ill for long periods of time, particularly if you're someone who needs to be hospitalized, or if you're frail, or you have underlying health conditions to begin with. The recovery can be very prolonged and protracted. I think there's also I know there's a small subset of people whose immune system does kind of jump the tracks and do its own dance, so to speak,
Sure.
such that people can develop these rare but real sort of autoimmune conditions. In 2020, I had a couple of patients, and this is anecdotal evidence, but a couple of patients who developed COVID pre-vaccine, one of whom developed RA, rheumatoid arthritis, that she had never had before. She didn't have it in her family. And it's hard not to believe that
Yeah.
having had COVID pre-vaccine tripped
Yeah.
the wire in her immune system. She got RA. She actually went into remission after about a year. I had another patient who developed giant cell arteritis, GCA, or polymyalgia rheumatica. Who knows if his COVID was related, but it seems awfully coincidental. But I would not call those long COVID. I would call that an immunogenic response to the
Yeah.
virus that in a susceptible person, because of genetic predispositions, got
Right.
sick, and we treated it. I think long COVID has become the boogeyman of COVID. And because so many people lack a doctor to figure out what the problem actually is, either just fatigue and a prolonged
Yeah.
recuperation versus a new illness,
Yeah.
lump it into this category of long COVID. It's not to say it isn't real. It's just that it's rare, particularly in the landscape we live in right now, where most people have had COVID and or vaccine doses. And so the population immunity, the collective immunity that we have together, provides somewhat of a shield against severe illness. It's not that it can't happen. It always will happen. Now that COVID is woven into the fabric of our viral sort of repertoire,
Yeah.
we're always going to have, sadly,
Yeah.
deaths and hospitalizations from COVID. We cannot have that, not have that.
Right. I would underline that. I mean, the pandemic sucked,
It sucks.
and
That's a great headline for
yeah,
this whole talk.
yeah, right. And like a lot of people, I became interested in looking back at history of other pandemics and plagues. And, we all as humans, react the same, right? We try to blame people for it. We try to like other people and blame it on, foreigners and blah, blah, blah. And it's both interesting and kind of sad that we as a species, right, basically haven't evolved. We do the same thing. And it's kind of perfect in our current political environment because we can just get all mad about it. Um, when I do wish we could sort of say, you know what we're mad about? We're mad about this damn virus, which,
Right.
kind of screwed up our lives for a couple of years, freaked out a lot of people. Um, and then we are still living with those consequences. And when I hear the same thing from people like, wow, I don't really want to go on this trip because I'm worried about getting COVID. I was like, don't worry about COVID anymore, but I'm worried about long COVID. I'm just like, boy, this disease has ruined us because that fear does a whole lot more harm than an actual infection at this point.
Yeah.
Um,
It's interesting to talk about that. I mean, I don't know about you, Adam, but when I was doing a lot of public-facing work, I was testifying in front of congressional committees about school reopenings and getting my ass kicked, even though,
yeah,
look, right, like that. I mean, it was like it didn't take a genius or to realize that the harms of the prolonged school closures, and was devastating to children, adolescents, and elderly people, and
yeah.
uh, uh, but but what was my point originally? I got lost in the sort of. I guess what I was saying is that I don't know what I was saying. Oh my god, I just got lost in what I was saying.
I wish I could help.
I totally lost my train of thought. I think that what I was trying to say is that the anxiety piece. When I was doing a lot of public facing work about the risks of the virus weighed against the risks of the mitigation measures. In a world where there's no menu option to not have the virus in our presence, like we had to make hard choices. There was no like magic wand. So we had to balance the risk of the virus with the risk of the mitigation measures. And depending on who you are, depending on your situation, make your decisions, pick your poison. Um, to talk about people's anxieties sometimes being out of proportion to the actual level of threat
Yeah.
was deemed minimizing or dismissive of people's anxieties, right? So I wrote an article for The Atlantic. Emily Oster had just written an article for The Atlantic about how sometimes our fears take on a life of their own.
Yeah.
That's actually the definition of generalized anxiety disorder, is when
Right. Right.
anxiety
Right.
takes on a life of its own. Like, we are entitled to anxiety. We are entitled to worry about whatever the heck it is we want to worry about. And it's possible that fear can take on a life of its own. So what I was speaking to, and I believe you were too, is that fear is you're entitled to it. However, fear, when it's being amplified by politicized messaging, by outrage inducing headlines, and when it's interfering with your ability to go on a vacation or see your grandkids after you've been vaccinated, after you've even had COVID, that's not to dismiss your anxiety. It's to honor it and say, like,
Yeah.
hey, you have anxiety. I see you. I feel you. I get it. I'm an anxious person myself. And let's calibrate that anxiety to the level of risk. Because what people are being deprived of is the facts. And they're just reading the headlines. They're just reading the sensationalism. And they're
Right.
just getting tangled up in the messaging instead of actually understanding the risk. And that's where I just feel sad for people who don't have a primary care doctor like you, or I think like me, who can say, look, take your trip. You might get COVID, but here is the potential downside of getting COVID on your trip. And yeah,
And I think the complexity to it, just to throw out two other things. I mean, I'm sure you had the experience where actually some people, COVID kind of gave them the license to live the way they wanted to
yeah.
live. The people who honestly, a lot of, human contact and stuff stressed people out. And you're like, I'm fine with that. And you had people sort of saying, I'm free now. I don't need to go out and see people. I can almost use this as an excuse because it's easier to say I don't want to get COVID than I just don't want to see you people. There's also the interesting data, which has now been reproduced a couple of times, that um, people with the worst kind of COVID anxiety are at the highest risk for long COVID. And that's not to say that, you're making up symptoms afterwards or something, but it's just that, we are one body, right? And if you get sick and you're super concerned and pay a lot of attention to the little disabilities that come after, you're much more likely to kind of amplify those. Um, and so boy, I'm not even sure that, a good, thoughtful primary care doctor with a lot of time is almost, enough for this.
Well, I mean, it's one of my favorite subjects actually, is to talk with patients about emotional health and I mean, I'm sure you agree with
Yeah,
this too, Adam, like, because I mean, it's invisible, right? Like, levels of vigilance, levels of fear, levels of worry, levels of
right.
risk intolerance about a particular issue, right? Um, and it's hard to quantify
Yeah,
fear or anxiety. And of
yeah,
course, people are entitled to having fears and anxieties. But it is, I mean, it's not always my favorite conversation to have, but I like posing back to the question with empathy and curiosity. Like, is it possible that the fear you're having about getting COVID or long COVID is out of proportion to what the evidence shows or to just what, we're seeing out there anecdotally in the field? And sometimes the people, and maybe you're listening here and you're thinking you're worried about long COVID, and I'm reading here that someone's worried about transmitting the virus to other people. You may not think you're anxious, and you may not actually be anxious. You may just not know the answer to the
yeah,
question. And
yeah,
so there's, we're talking about, arming people with evidence and science, and also arming people with the ability to make smart decisions for themselves. But you're hamstrung by the lack of clarity in the messaging, and you're hamstrung by the fact that we live in an anxious time, and we've just been through a pandemic where anxiety was, part of the
yeah,
air we breathe.
yeah, yeah.
Um, so people are asking very practical questions here. Like,
Okay.
let's go back to these questions because, like, should I get a vaccine dose to prevent transmitting the virus to other people? I gave a pretzeled, contorted answer to that because it's not a simple answer. But what would you say, Dr. Seafood?
Um, I, I'll be kind of hardcore on it, and I'll say no. I think that the most important thing you can do is what we probably should have all been doing, and I think we are actually doing better um, now than we did. But if you get sick, isolate yourself,
Right.
and I
Right.
think what we know is, like, 5 days with a bad upper respiratory tract infection is probably enough to get you through the time that you are the greatest risk to other people. The greatest risk is probably the first couple of days before you should get sick, and then the first couple of days after you get sick. If you wait 5 days and then get back out there, you're good. You're going to be protecting other people. And if you're super scared, if it's like, oh my God, it's day 6 and I was due to visit my aunt who's getting chemotherapy, give it another 5 days. Um,
Totally. Totally.
but don't change your own behavior. Don't change your decisions about vaccination. Don't change your decisions about Paxlovid because you're trying to protect other people. That may sound incredibly, egotistical, self-interested. I'm a terrible person saying that. Um, but I think that's actually taking care of other people and taking care of yourself the best that we can.
Well, let's put a finer point on it. If we thought that the vaccine blocked transmission to other people, this would be a different conversation. If we thought the vaccine was sterilizing, this would be a different conversation. So one of the reasons you get the MMR vaccine is because you are reducing the risk of transmission to other people. So it's a different vaccine altogether. We're talking about the COVID vaccine, which again, since 2021, since the Delta variant, landed on Earth, that ship sailed. It just doesn't block transmission. And so um, it's not that it
And,
can. Yeah.
and let me just pull back. This is a coronavirus, right? All of us, everybody who's old enough to be listening here, right, has had numerous coronaviruses over the course of their life. Why do they keep getting them? Because they keep mutating and they break through our immunity, and we infect everybody. And anybody who's got kids who's gone through school, they're like, oh my God, this terrible virus has swept through the school in the last 2 weeks. You know, that's a coronavirus, right? And that's what we're up against. And so there's just no way to be perfect about protecting yourself and about protecting other people.
Adam, I had a patient in the office last week who was sick. She had body aches, headache, runny nose, chest congestion. I tested her for COVID because we have a PCR test here because she wanted to know. She was going to visit some friends on a vacation. And it was like an important trip. And her COVID test, she was negative for COVID, flu, and RSV. She said, "Oh, great, now I can go on my trip." And I said,
Yeah.
"Whoa, whoa, whoa, whoa,
Right,
whoa! I
right,
mean,
right,
this is where we did harm to people. She's not unintelligent. She's a
right,
smart
right.
person. This is where we really messed with people's minds. Just because you don't have COVID, flu, or RSV doesn't mean all of a sudden you're not contagious to other people.
Yeah, yeah, yeah.
Being sick means you're contagious.
Right.
Actively sick means you're contagious, most likely. So I thought it was a perfect example of where we have mismessaged to people about COVID. There's actually nothing that special about COVID in 2025. Now that we've received so many vaccine doses and people have had COVID, it's just another virus in our arsenal.
And I think the COVID flu RSV test is another great example of, you know, giving care that people need and not necessarily what they want, right? So I spend every Friday morning in urgent care, which I staff with our residents. And, at least once we have this conversation where sort of someone comes in with an upper respiratory tract infection that they should have just stayed home. With, and they're there to get a test, right? And I do the counseling, like, it doesn't matter because you're too far out for me to offer you any sort of treatment for this anyway. Um, I don't think I should test you. It's unpleasant. It's a waste of money, and it's not going to change anything we do. That's a place that if people really want it, I'm like, okay, I'll do your darn test, so But really, it's only been 3 days. You should go home. You should rest for another couple of days, have a bunch of chicken soup before you start infecting other people like you've tried to infect me by, by
Right.
coming here.
Right, right, right. So what do you say to people about Paxlovid now in 2025? Are you prescribing Paxlovid for high risk patients when they get COVID? What do you think about it?
So I do not use it for people under 65, period. Um, for people over 65, I kind of give a shrug except to my highest risk people. So the people older 65, COPD, interstitial lung disease, asthma, serious pulmonary disease. Those people I will encourage it in. Most of those people, um, given conversations we've had, they are sort of calling for it. In most younger people, I am actively dissuading them from taking it. Um, again, I think we had really nice data in the pre-vaccine period, and I actually think this is a place that the previous FDA kind of fell short, because once we were at a time where we basically had, nearly 100% immunity, um, we should have been retesting that. And it would be easy to do a trial where we could figure out, what was the benefit of Paxlovid in someone who'd had COVID or someone who'd had 3 vaccines already, to see is this still beneficial. We don't
Right.
know.
Right. One of my favorite things about you, Adam Cifu, is that you say, I don't know. And that you shrug when people ask you questions. I mean, that is a sign of somebody who is humble, who is willing to say, I don't know. There's such a premium on certainty right now, right? I think
Right.
because we are living in an era of confusion and chaos and uncertainty, because in the medical space in particular, we're not sure who to trust. There's a premium placed on certainty, which is why like the Twitter algorithms and the algorithms on social media are
Yeah.
so
Yeah.
effective, right? Because
Yeah.
they reward messengers who are certain.
Right.
And if you're not certain, and if you're in the middle, not because you chose to be in the middle, but because you happen to be someone who's thinking through risk
Yeah.
in a more
Yeah.
nuanced way, or you're thinking through thorny problems and not having an immediate answer, your messaging may not get through as well.
Right.
People want certainty. They want answers. They crave, you know, a messenger they can trust and who they know they're going to be okay with.
Yeah.
The problem is that it's hard to find that person. It's also not really real life. So,
Right. And I would add to that, I think we're in like a snake oil salesman renaissance, right?
oh
Because
yes,
um, people who can be certain to a large audience are attractive, right? And those people, move products, sell books, generate clicks, whatever. Um, the problem is that we, you know, everything about how physicians practice are practicing to individuals, right? The advice that we can give to a large audience is not huge, right? It's wear seatbelts, drink clean water, get the childhood vaccines that you have to get. There are some things that you can tell everybody, but that advice is fairly few, and it's actually pretty boring, right? Like if I came on some show every week and said, you really should exercise and you shouldn't smoke and you shouldn't drink, people are going to lose interest in that pretty quickly. And the things that I have to talk either to my patients individually or certainly to an audience, man, most of it is, I don't know, weigh the risks and benefits here. And hopefully you have someone who can help guide you through the medical literature, which is A, complicated, and B, is often uncertain, right? I mean, many of the things that we do in the kind of critical appraisal, that I know you do on your site, that we do on Sensible Medicine, um, is that people can disagree, and really smart people can say, wow, I really think this article supports this practice, while someone else can say, nah, that's not strong enough for me. To say I follow the science is kind of simplistic as well.
of course, and I think it's a great point, and we're also talking about human beings, right? Human beings are dynamic, they're complex. I was talking to an oncologist a couple weeks ago who's treating one of my patients for advanced myelofibrosis that is transformed into acute myeloid leukemia
Yeah,
that has a molecular target for another round of chemotherapy,
yeah,
yet her life expectancy is pretty short,
yeah,
we think.
yeah,
And I was making the argument to the oncologist that even though we have a molecular target for this chemotherapy, which you can offer her, and he was going to send her up to Hopkins for a bone marrow transplant consult. She's 75 with advanced myelodysplasia. I was like, can we talk about being honest with this patient about what the predicted life expectancy and then talk about is, and then talk with her about what her goals are? Because I think we have to be honest about what the side effects of this treatment are, versus the benefits of, being at home and being in hospice. You and I both know that people end up going into hospice like the week before they die when they could be taking advantage of the dignity and quality of life in these precious weeks and months of their life. So the point about that I'm trying to make is not that, you should forego chemotherapy at the end of your life, but rather that most of the decisions you and I make in our life, in our practices as primary care doctors, are about data. They involve like understanding medical literature. They also involve understanding the person and the trade-offs, and then
Yeah,
a trust and rapport between patient and doctor is the sort of highway that is required for information and decision making to be made.
right. Right. And the great balance that I think, people talk about and that I think when things work well, um, is when, the doctor's job is to, in a way, give as close to truth as possible with prognosis, with the efficacy of treatment, with what to expect. The patient these days is going to bring some medical knowledge to the table, and that medical knowledge, needs to be respected, vetted, so on and so forth. But what the patient's bringing to the table mostly is, their values, their expectations, what they want out of, their remaining days. And that may be 50 years worth of remaining days, or it may be, 10 days worth it. Um, and I always feel like conversations work really well when physicians mostly and patients somewhat kind of respect what they bring to the conversation. And in, the case you were just talking about, um, that patient needs to have the knowledge to both um, consider what she wants for the rest of her life, to make a decision now, but then also to be equipped with the knowledge to sort of, jump ship on treatment in 2 weeks if things are changing for how she feels. And the doctors at that point, boy, just need to jump in and support it. That's an impossible decision
Yeah.
you just made. We're behind you. We're not trying to convince you that you need one more round of chemotherapy, or, oh, what are you doing? You need to be on hospice right now.
Yeah, no, sometimes I tell patients I'm like the Cheesecake Factory. Like I am giving you the menu. I don't believe in gatekeeping. I don't believe in like lying down on a train track based on my opinions, but I
Right.
do think I'm more than the Cheesecake Factory because I do have training and experience, and I know you, and I'd like to, but you know you better than I know you. So let's partner. How do you
I expect you're
trust?
a whole lot healthier than the Cheesecake Factory, we'll just
Yeah, I mean, they make a really good
say.
cheesecake, I'll say, but yeah, I mean, what kind of restaurant can make like 100 different meals in a single night? Like, I this is like, begs the question of what are they actually doing? So, Adam, so the average person who's reading the New York Times or the Wall Street Journal or what, how do they know who to trust? Can they trust the CDC? Can they trust what's coming out of the White House? How do people make sense of medical news? They can read your newsletter, which is amazing, Sensible Medicine.
Yeah.
Everyone should subscribe. It's so well done. It's so nuanced, and I love your framing about around thorny problems. I love your recent article about the electronic medical record. I was like,
Thanks.
amen, amen, amen.
Yeah.
So what advice do you have people when they're looking through headlines and thinking about what to believe?
Right. So I think first, and my advice is going to be, really ridiculously low level advice, but it's what I truly believe, is that one, people, everybody brings a lot of life knowledge into what they're reading, right? And so anything that seems too good to be true, it is too good to be true. Everything that you and I do in medicine provides small benefits or small decreases in risks over time. Okay. And so for most people, if they are not sick, right, if they are well, the benefit that we can bring to them is minuscule, right? And those people can forego most of the sort of screening preventative therapy that we offer um, with very little harm done. And so just about everything that you read in the newspaper that's mostly aimed at healthy people, right? Because that's the people who are reading newspapers. You should take that with an enormous grain of salt and say, huh, if it sounds like something I might be interested, that's something to, do some more reading on your own, talk to a doctor, talk to someone to determine if you want to do that. it is different once you're sick, right? If you have a real illness, that's where medicine today can offer an enormous amount, either treatment for your condition or the kind of secondary prevention, right? I've had a heart attack, I've had a stroke, I have atrial fibrillation. What can we do for you to prevent the complications of that illness? And I think that's where people should really be interested in seeking care and asking the difficult questions. And then I'll add one more thing is that when you're with the doctor, um, you're probably going to walk out of there, and in the days, weeks later, you're going to come up with more questions. You're going to come up with, what is the benefit of this treatment? How likely am I to benefit from this? What's the number needed to treat or the absolute risk reduction that goes along with this? And mostly when we're in the office, we're asking, how do you treat this? What are the side effects? And then we walk out. And those are good questions, but they're really not the most important questions, right? The most important questions is, okay, this is how you treat it, but how likely is it to benefit me? And I know what the side effects are. Is my hair going to turn blue in the first 3 days? But really, the more important side effects are like, what happens if I stay on this medication for 5 years? How much is this going to cost me? Will my insurance cover it? And often those are things that come out only days, weeks, months later, after you've been on the medication for a while.
Those are great points. I think one of the things that the current landscape has done in terms of medical messaging and certainly in the world of like medical optimization and longevity
Yeah.
influencers, not to reveal my bias there, um, is that there's
If
this
your
sort of,
doctor has longevity on their website, you shouldn't see them.
yeah, like, I mean, we could have a whole other episode about that. Like, longevity is typically good, but I would make the argument that longevity actually isn't what you want. I'm not against longevity.
Yeah.
I'm pro quality of life. I'm pro, arming people with tools to make complex decisions. Health isn't really to me about living longer. It's about living longer and better, and both they can coexist. But I think in the landscape we live in, where you have longevity experts and optimization as sort of the gospel and like willpower as virtue, there is the sense of like, oh, if I only do these 5 things or take these 10 supplements and I, cold water plunge, then I don't know, something good is gonna happen. Um, and so I think you're right that it's like pretty unsexy to talk about what you and I talk about
Yeah.
in our with our patients every day, which is like the basics.
Yeah.
Try to get exercise, prioritize
Yeah.
sleep, eat decent, nutritious meals with lots of protein and fiber and healthy fats, ditch the booze, except unless you wanna have a drink on a Friday
Yeah.
night or whatever, like, that's okay. It's just if
Yeah.
you have an addiction, that's one
Yeah.
drink is one too many. Um, you
I
know
like the way you say that because it highlights the fact that, a lot of, general medicine, primary care, most medicine is kind of drudgery, right? Um, and that drudgery is fine. Like anybody who does anything, right? Part of their job is drudgery. But that translates terrible to the sort of celebrity physician influencer these days. And so that's why many of those people, it's a little bit worrisome to pay attention to them and to take what they say.
well, I like what you write, and it's about framing, right? You're talking about the framing because you cannot possibly speak to. I think you have like 96,000 people subscribing to Sensible Medicine. I have like a mere 34,000. Um, but you can't, like, it would be disingenuous to say like everything you need to know about
Mm. Right.
XYZ because I don't know everything that you should know. I'm a perpetual student and everybody's so different. So
Right.
I don't trust people. So I don't
That's
trust
the
people who are so certain, and I don't trust people who say that I know that they know everything. Um, but to say that I don't know, or here's some uncertainty, and here's
right.
some boring basics is not the most sexy messaging.
Right. And it's funny because everybody would admit that the beauty of medicine is sort of the idiosyncrasies of all of us, right? And there may be like a finite number of diseases, but that finite number of diseases is huge. But then the way they affect the individual is infinite, right? In the symptoms people have, in the way they interact with the disease, in the way they describe the disease. Um, and like that's what we love about practice. That's why, although there's a lot of drudgery, I feel like, I could probably do this for another 60 years. I won't,
Yeah.
but I could.
Yeah.
Um, um, but it's also what makes it translate terribly, to the internet or, influencing.
That's right. That's right. Um, any other thoughts that I haven't brought up? Like, I mean, we have like 5 minutes left. Any
Yeah.
other sort of words of wisdom about the COVID landscape, who to trust, like
Um,
any sort of like, I mean, and if you don't have anything, Adam, that is perfectly fine. I'm just,
I mean, I might just fall back on, people are smart, right? And I think people have to look back at, um, what happened in 2020 was a super scary, hopefully once in a lifetime event. I do have one patient in my practice who was in the 1918 flu pandemic and then COVID. He's still going strong.
my God,
Um,
amazing.
but everybody now has lived, for the last, let's say, 2, 3 years in the COVID landscape. And how have we done? Most of us have done fine. Do I still see people when I attend in the hospital who have bad heart failure and they're in a heart failure exacerbation and we find out that they have the sniffles and we test them and they have COVID. We're like, oh, interesting. COVID's probably what tipped this person over this time, even though they were in the hospital 2 months ago and 6 months ago, also with their heart failure, which was not COVID. But most of us are living with this disease fine, and little you do is going to make a whole lot of difference. And I think the most important message we've already done is, you know what? If you're sick, stay home. Don't get other people sick because that's good for you and good for other people. And
Yeah. And just to reiterate what I wrote this morning, what I will recommend to my patients is that I will suggest to my over 65s to get the vaccine in the fall. I will suggest to my under 65s who have underlying medical conditions to get the vaccine. But there are caveats there. If you've had COVID itself within the previous couple of months, I won't encourage it because the virus itself
is a
helps your
great
body
vaccine.
mount an immune response that then helps protect you against other complications in the
Yeah.
future. But that's not a permanent protection, nor is the vaccine giving you permanent protection. Um, and then for like my young adult kids, I have 19, 21, 23-year olds. I will, they can do whatever they want because that's what they do at this age. But I won't encourage them to get vaccinated because they've had COVID a couple times, each of them. They've had a number of vaccine shots. And yes, as you said, there's a rare but real risk of vaccine-induced myocarditis from the COVID vaccine that is not an anti-vax talking point. It is simply true.
Yeah.
And it's a mild, tiny risk, but so is the risk of COVID to young adults who are generally healthy in 2025. So again, make nuance great again, make humility great again, make intuition and common sense great again, and ideally have a doctor who you can talk thorny issues through with, and hopefully in my lifetime and your lifetime, Adam, we will have sort of unfettered access to every American to have a medical home. Like that is my dream. Is that someday we live in a world where my kids through their insurance, have a medical home where behavioral health is woven in, mental health is part of the conversation, and, you know, that graduates coming out of medical schools are going into the primary care fields because they aren't gonna get mortally injured from electronic medical records and the grind of everyday life as a primary care doctor, and they go into the primary care fields because they get to see the whole person, not just their cholesterol and their blood pressure and their BMI, but they understand the whole person. And because right now, medical school graduates are largely going into subspecialty fields. They're treating 3 square inches of the body, and God love them. But we need people who, like you, talk to patients, do the kind of boring but essential work of caring for human beings. And it's the greatest privilege of my life. Some of it is really boring, but actually, no day is boring because people are infinitely interesting. And
Yeah.
the more I
Yeah.
get to know people, I've been doing this for 25 years, the patient relationships I have and then the trust that has been built over time for them to tell me, like, they're gay and they've told
Right.
no one else but me in their
Right.
40s. or they are having an affair, or they think they're depressed, or they are worried about something they're embarrassed to tell someone else what they're going to tell me. I mean, that is like the greatest privilege. Or the end of life conversations.
Yeah, yeah.
I mean, that is like my Super Bowl, is not that I wish upon people to be at the end of their life, but rather to be part of that conversation is a true honor. And it takes a lot of drudgery and boring conversations about cholesterol and, cutting back on your wine and, to get to a place where you can have those important conversations, and that rapport is essential. I wish everyone
The,
had access to that.
the lasting message is stay home when you're sick and convince your children to become primary care doctors.
Yeah, I'm working on my daughter. I'm actually not working on her because I'm like, I'm working on helping her think if she wants to do that. She's in
Yeah,
college right
yeah,
now, and she just came
yeah.
home and said, I think I might want to do pre-med. And I was like, oh, geez. But now I'm kind of like, well, okay, that could be cool.
Yeah, yeah, yeah. That's great. It's great.
We'll see. Adam, thank you for joining me. Thanks for talking through these thorny issues,
Yeah, yeah,
and we'll be in
terrific. Really
touch.
appreciate it. Take care.
All right, take care, everyone. Bye-bye.